Good morning, everyone. Today topic of discussion is approach to pyrexia of unknown origin. First of all, can anybody define fever? What is fever? How do you define fever? Abhidhamma. Fever is defined as detected temperature more than 38 degrees Celsius or 100.4 degree Fahrenheit. Today, learning objectives will be to learn about definition of pyrexia of unknown origin, classification, what are the different etiologies, how will you evaluate the case of pyrexia of unknown origin, and treatment and prognosis. Definition of pyrexia of unknown origin was first defined in 1961 by Peterhoff and Beeson as the following. It is temperature more than 38.3 degrees Celsius, 101 Fahrenheit on several occasions, more than 3 weeks duration of illness or evaluation in OPD, and failure to reach diagnosis despite 1 week of inpatient investigation. Currently, the duration of illness has been reduced to 14 days. According to Nelson, PU is defined as temperature more than 100.4 degree Fahrenheit, 38 degrees Celsius, lasting for more than 14 days without an obvious cause, despite complete history, physical examination, and routine screening laboratory evaluation. Classification: classic PUO, nosocomial, immune deficient, and HIV associated. In this presentation, we will mainly consider on classical PUO. Now, what is classic PUO? It is defined as fever more than 38 degrees Celsius, that is 100.4 degree Fahrenheit, for more than 3 weeks with at least 2 outpatient visits or 1 week in hospital. Etiology mainly include infectious and non-infectious. In infectious, it can be bacterial, viral, rickettsial, fungal, parasitic, or localized infection. In non-infectious, it can be inflammatory, neoplastic, or miscellaneous cause. According to Nelson, infections account for most of the cases of the PUO, 40 to 50%, followed by inflammatory causes that includes connective tissue disorders, followed by neoplasm and miscellaneous causes. Around 15% of FU remain undiagnosed. FU was classified as undiagnosed if there is no evidence of the cause of fever and if there was complete spontaneous recovery even though the fever had persisted for several weeks or fever resolved during investigation. In many cases you come across that after thorough examination and investigation, you don't get any etiology for the fever. That are classified as undiagnosed FUO. These are the various studies that compares the etiological causes of FUO, and results shows that infections are the most important causes, followed by malignancy, followed by connective tissue disorders, and at last some fever remains undiagnosed. Recent study was in Osmania Medical College in 2020 that showed infections account for 38%, followed by malignancy 24%, followed by non-infective inflammatory disorders, and followed by undiagnosed cause. This is from the table in Nelson that describes various infectious causes. In bacterial, you come across tuberculosis, salmonella, brucellosis, listeriosis. In localized abscesses, it can be anywhere in the body. It can be abdominal, brain, dental, rectal, perinephric. In localized infections, it can be osteomyelitis, mastoiditis, pyelonephritis, sinusitis, infective endocarditis. In virus, CMV, EBV, HIV, herpes viruses can be responsible. In fungal, blastomycosis, histoplasmosis, coccidioidomycosis. You should also look for other disease like rickettsial disease, Q fever, Rocky Mountain spotted fever, tick-borne typhus. Parasitic causes includes malaria, amoebiasis, giardiasis, toxoplasmosis. So every type of infection can present as prolonged fever and pyrexia of unknown origin. Inflammatory disorders includes granulomatous disease like Crohn's disease, granulomatous hepatitis, sarcoidosis, hypersensitive pneumonitis, drug fever. Then rheumatological disease includes JIA, rheumatic fever, SLE, Behçet's disease, juvenile dermatomyositis. Kawasaki can present as PU, polyarthritis nodosa, and sarcoidosis. Malignancies includes neuroblastoma, Wilms tumor, pheochromocytoma, lymphoma, leukemia, Hodgkin's disease, or Ewing sarcoma. Other causes includes miscellaneous causes like Addison's disease, autonomic neuropathies, familial dysautonomia, or factitious fever. In factitious fever, the parent complain the child is having fever. They have no any documentation, but they feel that the child is always warm and the child is running fever. Actually, the temperature is normal only. Then these are the various studies which shows that in infectious disease, tuberculosis was the most common infection, followed by viral infection, followed by enteric fever. Similarly, there is another study in New Delhi in which it was found that enteric fever was the most common infection presenting as FVO, followed by visceral leishmaniasis and tuberculosis. Then how should a child with PUO be evaluated? You should remember that PUO is more likely an unusual presentation of a common disorder rather than a common presentation of a rare disorder. To reach the diagnosis, detailed history and physical examination is important, and you should avoid ordering the large battery of tests unnecessarily, and tests should be guided based on history and examination. In history, you should know about the onset of fever, duration of fever, whether it is acute or chronic, pattern of fever, whether it is continuous, intermittent, associated symptoms according to various systems, any history of chronic infection suggestive of immunodeficiency. Then there are certain points that you will usually miss in history that should be asked. If there is any history of drug intake, because if the offending drug is stopped, then the fever subsides within 48 hours. History of recent immunization in children, history of blood transfusion, then history of exposure to animals, and history of travel. These are the history points that you usually don't ask to the patient, that should not be missed. Then in general physical examination, you should look for detailed head-to-toe examination, because you can get clue from any site. Like if there is sinus tenderness, it can point towards sinusitis. You should look for the oropharynx, any ulceration, any gingival stomatitis, any pharyngeal vesicles, which can be seen in Coxsackie disease. Any focus of infection in tooth, that is periapical abscess, can present as fever. You should look for any eye changes. If there is choroid tubercles, it can show that there can be tuberculosis. If there is road spots, it points towards endocarditis. If there is murmur on auscultation, you should think of infective endocarditis. In skin and nail changes like petechiae, splinter hemorrhages, subcutaneous nodules, point towards vasculitis. In abdomen, you should look for the organomegaly. Enlarged iliac crest lymph nodes, splenomegaly, points towards lymphoma. Splenomegaly can be there in endocarditis also. Then if there is pain with bone palpation or passive joint range of motion, it points towards any joint or bone involvement. It is osteomyelitis or arthritis. In lower extremities, you should look for deep vein tenderness, thrombosis or thrombophlebitis. Similarly, if there is perirectal fluctuance tenderness, it points towards abscess. So after taking detailed history and examination, you come to investigations. There are certain screening tests. If the child is coming to you in OPD with fever, at first visit, you should look for whether fever is high grade, low grade, whether there is acute onset, chronic onset, associated symptoms. You should reassure the parents that if there is viral illness, that the fever will subside within 48 to 72 hours. And if the fever persists, they should come back. Then, what are the screening tests that you should order? It includes hemogram, CRP, procalcitonin, basic metabolic profile, urine analysis, urine and blood culture, chest X-ray in case pulmonary symptoms are there. Then, if the parent is coming again with persistence of fever and you are not getting the focus of infection, then there are additional tests that you should order, like special cultures, like lumbar puncture or serology according to various infections, biopsy, and special imaging like CT scan, MRI, radionucleotide scan to look for the site of infection. Now we will discuss about various case presentations. There is a 3-year-old male child coming to you with fever on and off since 14 days. Fever is up to 101 degree Fahrenheit, associated with one episode of vomiting 1 week back. There is no history of cough, rash, joint pain, bleeding from any side, no history of seizure, no history of weight loss, no history of any urinary complaints. On examination, there is positive finding in abdominal examination, hepatosplenomegaly. Liver is 5 cm palpable below right costal margin, soft in consistency with smooth surface. Spleen is about 2 cm below the left costal margin, firm in consistency and smooth surface.
So you can ask the JR.
So based on history and examination, what will be your differential? 3-year-old male with history of fever since 14 days and vomiting. So based on history and examination, differentials will include typhoid, it can be malaria, it can be tropical infections like dengue fever, scrub typhus, or it can be tuberculosis. In malignancy, it can be lymphoma or leukemia. Then on investigations, this was the CBC. Hemoglobin was 9.9, platelets were 91,000, MCV, MCH was 72/23. Then this was a metabolic profile. So based on this investigation, any clue? So in this patient, Vidal showed TH titers of more than 160 and 120, 100, 320. Blood culture was done that showed Salmonella typhi. So diagnosis in this case was enteric fever. Now, what are the clinical features of enteric fever? In first week, the child presents with fever, abdominal pain, constipation or delirium. Fever is step-ladder type. Initially, it is low grade, then there is gradual increase in temperature. In second week, associated symptoms like abdominal distension, vomiting, on examination, hepatosplenomegaly can be there. And in third week, complications like confusion, psychosis, intestinal perforation, diarrhea can be there. Now, what are the characteristics of or changes that we see in a patient with typhoid? In hemogram, there can be anemia. If there is intestinal hemorrhage, then there will be severe anemia. WBC count shows leukopenia with neutrophilia, eosinopenia. Monocytosis can be there. In platelets, thrombocytopenia. There can be transaminitis, like we saw in the investigation. Then in Vidal test should be ordered at end of 1 week of fever. It can be negative in 30% of culture proven cases, like in case of prior antibiotic therapy and failure to mount immune response. And titers more than 1:160 are usually significant. Third investigation is typhidode test. It measures the IgM and IgG antibodies against the 50 kD outer membrane of Salmonella typhi. It can be ordered in first week. Sensitivity is around 70 to 80%. Then gold standard is blood culture. In first week, it has sensitivity of 90%. In second week, 75%. In third week, 60%. Thereafter, till subsidence of fever, sensitivity is 25%. So on outpatient basis, you will start the patient on cefixime at 20 mg per kg per day for 14 days. If the fever persisted despite 14 days.
One thing, if the child is not able to take orally, if vomiting is severe, it's better to admit.
Then you go for the IV antibiotics like ceftriaxone. Then next case presentation. There is 7 years female presented with fever since 2 months. Fever is above 39 Fahrenheit, presented mostly during evening, partially relieved by medication. There is no history of cough, no history of vomiting, no history of headache, altered sensorium, no history of weight loss, decreased appetite, no history of rash or joint pain, and normal urine and bowel habits. Child was taken to various hospitals for above complaints, given around 2-week course of antibiotics, although blood investigations were inconclusive, but not much relief. So there is history of prolonged fever only, no history of cough, no history of weight loss or loss of appetite. Differential can be tuberculosis, anti-fever, tropical disease.
Sometimes you're partially treated enteric fever. Some inadequately treated enteric fever, those fever can run for months. Always keep that in mind. TB is a possibility, but partially treated enteric fever also should be.
Then it can be infective endocarditis or any non-infective autoimmune disease can present with fever up to 2 months, or malignancy can be there. On examination, appearance was normal. There was pallor, mild, non-tender cervical lymphadenopathy present around 1 mm in size. Systemic examination was normal. Initial investigations, hemogram was almost normal. Biochemistry metabolic profile was normal. CRP was raised and ESR was 71. List infective serologies were negative for Salmonella, Brucella. Blood culture was sterile. Montex test was positive, and echocardiography was normal. Which investigation is not mentioned as? So this is a chest X-ray. Based on investigation, history was reviewed. On repeat history, it was found that grandmother had pulmonary tuberculosis and was on ATT since 4 months. Then we sent the NAT test, gastric lavage for AFP and gene expert. Gastric lavage for gene expert came out to be positive. So based on history and investigations, diagnosis was tuberculosis. In third case, there is 12 years old female with complaints.
Abhinami can read.
So there was positive history of fever, high grade, 2 to 3 spikes per day, along with generalized weakness and fatigue. So you will keep in mind the infectious cause as one of the differential. On examination, child was febrile. There was no pallor. Eye, tongue, genitalia was normal. Only positive finding was there was pansystolic grade for murmur on auscultation. On abdominal examination, there was no organomegaly. Now the differentials. So then going to investigations, hemoglobin was 9.5. There was leukocytosis, thrombocytopenia, and CRP was raised. The rest of the investigations for infectious disease, Vidal test, Malaria parasite test was normal. Chest X-ray was normal. Montix was negative. Dengue serology, urine culture was normal. What other investigation would you order? So when the blood culture report came, it showed the Streptococcus viridans. So in this case, you will suspect the infective endocarditis possibly, and you will go ahead with echocardiography that showed anterior mitral leaflet with vegetation, moderate AR and mild PR. So diagnosis is possible infective endocarditis. This patient need prolonged antibiotic treatment, follow up with repeat echocardiography and blood culture. So it's important to keep infective endocarditis as a differential diagnosis in a child presenting with fever more than 2 weeks, either with no peripheral stigmata of infective endocarditis. You should examine the CV system to look for any murmur, and if the blood culture is positive, then you should go ahead with further investigations of infective endocarditis. Next case, there is 2 years old male child presented to outpatient clinic with complaints of fever that is persistent type with 1 to 2 spikes per week measuring up to 105 degree Fahrenheit for more than 2 weeks, associated with rash that comes with fever and settles down once fever goes down since 1 week. There is no other positive findings, no cough, no abdominal pain, vomiting, no weight loss. Differential diagnosis. It can be viral infection, it can be chronic infection like tuberculosis, but less likely to be presented with rash, tropical infection, infective endocarditis, or malignancy. No rash. On examination, the child was febrile, and on physical examination, pallor was present. There was palpable posterior cervical lymph nodes 2 into 2 centimeter, erythematous maculopapillary rash over trunk. On systemic examination, there was hepatosplenomegaly, liver 4 centimeter palpable below right costal margin, and spleen 3 centimeter palpable below left costal margin. So this was the investigation. Hemoglobin was 10.9. These were the other investigations. Blood culture was negative, ASO titers were normal, C3, C4 was normal, ANA was negative, LDH was normal, triglycerides were normal, and serology for brucella, leptospirosis were negative. To look for any bone marrow infiltration, we got the bone marrow aspiration biopsy that was normal. So based on results of investigations, we started the patient on antibiotics, but she continued to have multiple episodes of fever with chills, which were associated with mild joint pain in between, and following test, diagnosis of systemic onset juvenile idiopathic arthritis was made based on consideration of available clinical and laboratory findings. She was started on oral naproxen, following which she was symptomatically better and discharged from the hospital on 10th day of admission. After that, on follow-up visit, she was afebrile. So always keep in mind that systemic GIA is a diagnosis of exclusion. You should suspect GIA if the child is presenting to you with fever more than
JA, not all JA.
systemic onset GIA.
It is systemic JA, not systemic onset JA.
Systemic GIA if it presents with fever more than 2 weeks, with or without arthritis, with rash. Like this is the criteria, ILAR criteria, which defines as arthritis more than one joint with or preceded by fever of at least 2 weeks in duration that is documented quotidian basis. The parents will say that sometimes a child is having high grade fever, then the fever subsides to normal for at least 3 days and accompanied by one of the following: evanescent erythematous rash that was present in our case, generalized lymph node enlargement, hepatosplenomegaly, and serositis like pleuritis or diffusion. Exclusions include psoriasis. So, diagnosis of systemic GIA is made after exclusion of other disease and
This is one another important point. The diagnosis of systemic GIA, it is made after exclusion of other diseases. So the treatment of choice would be steroids, corticosteroids and systemic JA. But if you start steroids, you may wash away your leukemia cells and the diagnosis may get delayed if there is underlying leukemia. So we always do a marrow, exclude malignancy, that is lymphoma or leukemia, and then we make a diagnosis.
Next case, 1-year-old male child presented to you with complaints of fever and irritability since 2 weeks. Fever is high grade with a maximum temperature of 39.5 degrees Celsius. No history of cough, cold, no history of headache, seizure, vomiting, rash. There is history of decrease in appetite present, normal urine and bowel complaints. Received meropenem for 7 days and erythromycin for 5 days outside, but fever persisted.
Oh no, don't go with the fact that if the history is not there, then the infective causes are less likely. Don't go with the fact. Just how will you proceed next? Such a child comes to you in OPD. What else you will ask in the history? What else you will see in the physical examination, and how will you proceed?
Differential diagnosis will include one is tuberculosis because it is most common, bacterial causes, viral causes. You can keep
Scarlet fever will be less likely because scarlet fever will respond beautifully to your amoxicillin. Here the child has received meropenem, all kind of stuff. So scarlet fever is very, very unlikely. Again, enteric fever, very, very unlikely.
Then it can be Kawasaki disease according to age, 1-year-old child with fever and irritability. Infective endocarditis, less likely in this case. In age, examination, mild pallor was there. There was tender lymphadenopathy, 2 centimeter over the posterior triangle of the left side of the neck, mild throat congestion, systemic examination was normal. So in this child, we got the echocardiography done that showed the dilatation of coronary arteries. Then the CT coronary angiography showed giant aneurysm of left ascending artery and right coronary artery. So in this case, diagnosis was Kawasaki disease. It was diagnosed only after echocardiography. Not all clinical signs were present in this case except fever, irritability and examination cervical lymphadenopathy.
So 1 week fever, no response to ceftriaxone, and especially if it is a younger child, this possibility should be kept in mind.
So patients who lack full clinical features of classic KD are often evaluated for incomplete KD. If coronary artery abnormalities are detected, the diagnosis of KD is considered confirmed. So incomplete KD can present with echocardiographic changes. There can be sterile pyuria. They can present with arthritis along with fever. So based on that, you will get all the features of Kawasaki. It's not in all cases. Next case, 4-year-old female boy with fever and body pain since 3 weeks. Fever is up to 101 degree Fahrenheit, not relieved by medication. There is history of 1 unit of PRBC transfusion outside for anemia. On examination, vitals was stable. There was hepatosplenomegaly. Outside treated on outpatient basis with antibiotics. Probable diagnosis. Differentials, it can be tropical infection, it's to hemolytic anemia, malignant. So on examination, vitals was stable, sternal tenderness was there, there was pallor, generalized lymphadenopathy, and hepatosplenomegaly. So now the diagnosis narrowed down to a malignancy. We will go with investigations. Hemoglobin was 7, platelets were 26,000, TLC was 30,000. Most important in peripheral blood smear, blast cells were there. So diagnosis. So these are the workup that you will do to look for the malignancy. Final diagnosis will be based on a bone marrow examination. The next case, 6 years female presented with fever since 3 weeks, right hip pain and restriction of movement since 2 weeks, no history of joint swelling, no history of cough, breathing difficulty, no history of vomiting, pain in abdomen, no history of rash, normal urine and bowel habits. Differential can be chronic infections, localized abscesses, it can be Kawasaki disease, it can be leukemia. On examination, appearance was normal, and on local examination, right hip internally rotated, painful restriction on movement. Systemic examination was normal. So on probing history, it was found that the child had been drinking unboiled goat milk since a couple of years and has a direct contact with goat at home. Brucella IgM titers came out to be positive with blood culture showing growth of brucella. The child was started on combination therapy of rifampicin and doxycycline and became afebrile in 48 hours of treatment. So in this
Okay,
case,
just wrap up in 2 minutes.
so what is the structured approach to PUO? A fever more than 100.4 degree Fahrenheit, an illness more than 2 weeks. You should go with complete history and physical examination. Stop all antibiotic treatment, and you should not go for empirical antibiotic treatment. Potential diagnostic clues present, then guided diagnostic test. Otherwise, screening test as discussed before, hemogram, ESR, CRP, urine analysis, urine culture, blood culture, chest x-ray, metabolic profile. You should exclude the manipulation with thermometer, any history of drug fever. You should ask for any history of travel, any animal contact. If there are positive results on screening test, then guided diagnostic test should be followed. If potential diagnostic clues are absent, you should go ahead with further additional investigation to look for the hidden causes, any abscesses, CT, MRI can be done. And then based on the causes, there are specific investigations for infections like special cultures like lumbar puncture, serology for Brucella, Leptospira, echocardiography, special radionucleotide scans for malignancies, a bone marrow examination, uric acid, lymph node biopsy is important. For connective tissue disorders, ANA, ASO, ANCA, C3, C4, muscle and skin biopsy can be done. Then FU, usually an atypical presentation of a common childhood illness. The ultimate treatment of FUO is tailored to the underlying diagnosis. They have better prognosis than adults. Most important is detailed history and examination. Empiric treatment may mask diagnosis of life-threatening oncologic infections and autoimmune disease. In as many as 25% of cases in whom fever persists, the cause of fever remains unclear even though after thorough evaluation. So take-home message is fever does not always due to infection. Malignancy is also an uncommon cause of PUO. 1/3 of the PUO cases don't have definite diagnosis. Be guided by your history and examination. Rule out malignancy before giving steroids. So any child coming to you with prolonged fever in OPD, before prescribing antibiotics, you should do detailed physical examination and order some investigations before prescribing antibiotics.
And it is always better to do an inpatient evaluation rather than evaluating in the OPD. So if it is not a common enteric fever, or even if it is enteric fever and not responding to your oral cefixime, get the child admitted. And never ever change an antibiotic, second line antibiotic, or add any antibiotic in your OPD. If you are thinking to add something in addition to cefixime, then that is the alarm for you. This could be something serious. This is not a simple enteric fever.
Usually we take 14 days. Revised grade is 14 days.
Because that is for theory. In practically what will come, children will come with 10 days of fever. Okay. So you should know the practical approach. Definitions you can learn for your theory examination. So how will you narrow down your diagnosis based on history, physical examination, and basic CBC, chest x-ray? You should know these things.